Preeclampsia and the uric acid coagulation connection, unraveling a complex relationship. Preeclampsia, PE, a pregnancy-specific syndrome characterized by hypertension and proteinuria, poses significant risks to both maternal and fetal health. But here's where it gets intriguing. Emerging research suggests a complex interplay between elevated serum uric acid, UA, levels and coagulation dysfunction in PE, a connection that could revolutionize our understanding and management of this condition. This article delves into the latest findings, exploring the potential mechanisms linking UA to coagulation abnormalities and their clinical implications. The uric acid enigma, contributor or consequence. Serum UA, a byproduct of purine metabolism, has long been recognized as a marker of oxidative stress. Studies consistently show higher UA levels in PE patients compared to normotensive pregnant women. However, the nature of this relationship remains controversial. Is elevated UA an active player in PE pathogenesis, promoting endothelial dysfunction, inflammation, and oxidative stress, or merely a byproduct of reduced renal clearance and tissue ischemia? This question lies at the heart of the debate surrounding UA's role in PE. Coagulation dysfunction, a key pathological feature. PE is also characterized by coagulation abnormalities, often manifesting as a hypercoagulable state and, in severe cases, disseminated intravascular coagulation, DIC. Research suggests that disruptions in the coagulation fibrinolysis system may precede clinical symptoms, highlighting its potential role in early disease progression. Parameters like platelet indices, prothrombin time, D-dimer levels, and plasminogen activator inhibitor 1, PAI-1, have shown promise as predictive markers. The intriguing link, UA and coagulation. And this is the part most people miss. Recent studies hint at a potential intrinsic link between elevated UA levels and coagulation dysfunction in PE. While the underlying mechanisms are not fully understood, converging pathways involving endothelial cell activation, oxidative stress, and inflammation may connect hyperuricemia to the prothrombotic state observed in PE. Mechanisms unveiled, a multifaceted interaction. Research suggests several mechanisms through which UA might influence coagulation in PE. NF-kappa B pathway activation. UA may activate the NF-kappa B pathway, leading to increased production of pro-inflammatory cytokines like IL-6 and TNF-alpha, which in turn promote coagulation factor expression and platelet activation. Endothelial dysfunction. High UA concentrations can inhibit nitric oxide synthesis, impair endothelial function, and increase adhesion molecule expression, promoting leukocyte adhesion, inflammation, and platelet aggregation. Tissue factor induction. UA can stimulate vascular endothelial cells to release tissue factor, TF, initiating the extrinsic coagulation pathway. Clinical implications, towards precision management. Understanding the UA coagulation connection has significant clinical implications. Joint monitoring of UA and coagulation markers like D-dimer, PAI-1, and VWF could improve PE classification, risk stratification, and early prediction. Furthermore, dynamic monitoring of these parameters may guide personalized treatment strategies, potentially delaying or preventing PE onset and improving maternal-fetal outcomes. Controversies and future directions. Despite promising findings, the relationship between UA and coagulation in PE remains complex and controversial. Most studies are retrospective or observational, necessitating large-scale prospective studies to establish causality and elucidate specific molecular pathways. Additionally, the optimal use of UA as a diagnostic or prognostic marker in PE requires further investigation, considering its potential as a biomarker within specific PE subtypes or as part of multi-marker prediction models. A call for further exploration. The intricate dance between uric acid and coagulation in preeclampsia presents a fascinating research frontier. While we've made significant strides in understanding this relationship, many questions remain unanswered. Are there specific PE subtypes where UA plays a more prominent role? Can interventions targeting UA levels improve coagulation abnormalities and PE outcomes? These thought-provoking questions invite further investigation and discussion, paving the way for a more nuanced understanding and effective management of this complex pregnancy complication.